Good afternoon, ladies and gentlemen. We're going to begin our webinar. Welcome. My name is Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council. And we want to thank all of you for joining us today. This is another educational webinar, and it's hosted in coordination with Hospital Pricing Specialist, an associate member of the council. Today's topic, cracking the code. Understanding CMS price transparency and compliance. As you know, this is a hot topic, and it's one that's been a major shift that's occurring in healthcare today. And we're going to explore the evolution of some of the price transparency regulations, their compliance requirements, and the risk of non-compliance as we navigate these changes. We're delighted that we've got an expert speaker today, Randi Brantner, who serves as Vice President and Chief Operating Officer at Hospital Pricing Specialist. I think she's spoken to us at a webinar previously last year, and we know her level of expertise, and we certainly are so delighted that she could join us today. So we've got a great turnout, and we look forward to discussing this today. But one administrative item, if you have questions, please type them in the question box, and we'll answer them at the end of the webinar. With that, and without any further ado, it's my pleasure to present Randi Brantner.
Thanks, Steve. Yes, thank you. Welcome, everyone. Thank you for joining this presentation on CMS price transparency. As Steve said today, we're going to explore the evolution of the price transparency regulations, talk a little bit about the current compliance requirements, risks, obviously, of non-compliance, and then our strategies for navigating these changes effectively. My name is Randi Brantner, and I am the VP of Operations for Hospital Pricing Specialists. Now, price transparency is a major shift in healthcare, aimed at empowering patients and increasing competition. However, it also brings several regulatory challenges for hospitals and payers. So today we'll break down the history, current requirements, risks, and strategic approaches to compliance. So let's get started. First off, at Hospital Pricing Specialist, HPS, we bring over a century of collective experience in charge master management, healthcare pricing, reimbursement, and payer analytics. Our leadership team featured here has successfully completed pricing projects for hundreds of clients, from critical access hospitals to large healthcare systems with several thousand beds. Our deep knowledge and extensive experience make us a reliable partner in navigating the complexities of healthcare pricing and price transparency. We provide tailored, comprehensive solutions backed by advanced technology and a dedication to achieving optimal results. Our proven success and flexible approach allows us to attain excellence in pricing and charge master management. We also have a 100% price transparency compliance score and back every machine-readable file with a written guarantee. If CMS finds your file non-compliant after you've been working with us, we pay the fine. So here's why we put our money where our mouth is. So to talk a little bit about the evolution of our price transparency requirements. Now, CMS started introducing price transparency way back in 2015 with the Affordable Care Act. And this was when it first required hospitals to provide a standard list of charges upon request of the patient. But it wasn't until the 2019 final rule that they really began to require hospitals to publish standard charges in a frequently updated machine-readable file online, not just upon request of the hospital. Now, President Trump's first term, he had an executive order in June of 2019 that promoted increased availability of meaningful pricing information for patients. So, CMS was tasked with creating a way for hospitals to display standardized information to support healthcare consumerism. CMS has been really clear that this is just the first step in bringing transparency to patients and only part of the answer. So their hope is to eventually increase competition, decrease costs, and to address the barriers that limit a patient's understanding of their hospital bills. Now, it's important to note that many states have been requiring a version of price transparency for many years. So with the exception of the payer-specific charges component, states' efforts to address surprise billing issues really hasn't gone unnoticed. States like California, among many others, have required annual posting of charge masters, a selection of hospital financial reports, and or a list of common procedures for many years, which really demonstrates that states have been proactively addressing transparency for a while. Now, since CMS price transparency really kicked in 2021, other states have also jumped on and require some form of price transparency or regulation. Now, CMS requirements have continued to evolve, as you can see on this slide, including 3 significant changes to the regulations just in 2024 alone. So starting back in 2021, CMS outlined the required data elements needed to meet transparency requirements, using that machine-readable file and a separate shoppable services list or patient estimator. But it really didn't at the time provide a format for that file or a prescribed way to post this information. But over the years, as you can see, CMS has created a template layout and further defined those data elements and the posting location of the files. The CMS ruling effective in January of 2024 now requires the hospitals to create a text file in the root folder of the hospital website, which provides information about where the MRF can be found and other transparency resources, as well as a transparency footer linking to that same information. And I'll walk through the details of what that looks like on a live site later on in the presentation. Now, in July of 2024, CMS also required hospital MRFs to conform to a certain template and data specification by really standardizing the MRF, which I think was very helpful, at least from our perspective. And then CMS obviously started increasing enforcement. In January 2025, we got a little bit of a curveball where they started having additional data requirements related to drugs, modifiers, and estimated allowed amounts. So we're going to talk a little bit now about what that all means. Now, back in 2021, which seems like forever ago now, the deadline for that CMS regulation was what CMS terms as the comprehensive machine readable file. CMS states that the machine readable file, or MRF, so I apologize if I use that occasionally, the MRF is not meant for patient use. It is meant for innovation and for vendors to create apps, comparison tools, searchable databases. It's not meant for patient use. But the file has to contain each item and service that's available and or performed by each hospital in this single file. The 2 formats that are allowed right now are CSV and JSON data formats. Now, to ensure compliance with the guidelines, hospitals had to publish 5 standard charges. And again, this was back in the day. At the time, it was the gross charge, the self-pay cash price, the payer-specific negotiated charges, and the min and the max of those negotiated charges. But the new template file in July of 2024, as you can see here on the screen, there's a lot more data required for the CMS required template nowadays in order to meet our requirements today. So let's walk through a little bit of what these definitions are and what that means. First of all, at the bottom of the slide, you'll see I've added a link to the CMS Gov GitHub. For those of you who may not know, a GitHub is a web-based platform that allows developers to store and manage and share code that facilitates collaboration and open source software development. So CMS has basically put all of the information into this GitHub for us to be able to determine what needs to go in this file, what are appropriate values, and things like that. So this is available to anyone if you just click on that link. Now, keep in mind, it's pretty technical, but it is very, very useful. Now, according to the CMS.gov GitHub, the CMS template requires that general data elements listed here be stated one time at the top of the file. For example, the column headers you see listed on the left, the hospital name, the address, the license number, those would be in row 1 of your CSV files, with the values of those fields for those columns in row 2. So again, we're just listing at the top of the file things like the hospital name, the last time the file was updated, the address, the license number, and then an affirmation statement, basically saying the information in this file is true and accurate to my knowledge, right? This, again, came from the GitHub, and you can see there is a description of each of the elements and an indicator on if blanks are allowed in this field. From there, we start outlining the actual standard charge information. So in row 3, this is where we're going to start listing all of the standard charges and their required elements. Now, in the example I'm using today, I'm using a CSV tall format because that is the one we prefer to use at HPS. But the CSV wide format does use the same elements with a couple of little differences. The difference between a CSV tall is obviously the payers are all listed in a single column going down, whereas a CSV wide format has a column for each payer. So depending on the size of the hospital, you may need to go wide or you may prefer to go tall. Either way, the third row of the CSV file will have the column headers again as they're listed here on the left. And the next few slides kind of walks you through the definitions of those data elements. Keep in mind that any field that has a type enum, E-N-U-M, must be selected from a list of CMS valid values. So for example, for code type, the third line here, enum would be things like CPT, HCPCS, NDC, RC, which is for revenue code, things like that. The link at the bottom, again, shows you the CMS resources for this. So to summarize, we're looking at the description. So the chargemaster description or the DRG description or the procedure description. The code pipe 1. So that's the code that you're using, whether it's the NDC, the CPT, the HCPCS code. And the next column is the type, again, where you're selecting from that CMS prescribed list of what that code represents, whether it's a revenue code or an NDC. The setting, this is where we're saying this particular charge is used on the inpatient, the outpatient, or both. The reason for that is your terms might be different for a certain procedure in the inpatient setting than it would be in the outpatient setting when it comes to your reimbursement factors. Drug unit of measurement and drug type of measurement, these two go together. And again, these are new as of January. This is where you're saying this tablet is 100 milligrams. So the unit of measurement would be 100. The type of measurement would be milligrams. So you've got to really dig into that pharmacy formulary and match those up in the data as well. Standard charge gross is your gross charge master price, whatever price is listed in the charge master. And then the discounted cash would be your self-pay discounted price. So if you charge 85% of charges, you have a 15% discount for self-pay people, you would have an 85% of the gross charge in that discounted cash column. Continuing on. So again, payer name and plan name, those go hand in hand. You might have Anthem plan, but your plan names may be PPO, EPO, HMO, whatever that might be, might differentiate down from there. Modifiers, again, this is a newer piece. Any modifier that is going to adjust a payment or adjust a gross charge needs to be listed separately. So payment modifiers like the 50, the 52, 80, QW, whatever those are, those need to be indicated with their various standard charge amounts in the file. Next, the next three on the list are the negotiated dollar, negotiated percentage, and negotiated algorithm. Now, payer-specific negotiated rates refer to the rates as agreed to with the payer, and this would be listed in your hospital contracts with the payers. Now, the charge methodology used to calculate the negotiated rate should be outlined in the file. For example, if you're doing case rate or per diem, whatever that might be. Whenever possible, CMS encourages and prefers that the negotiated charge be provided in a dollar value. So even if you have a percent of charge term, if you can calculate that as a negotiated dollar, they want to see that in the negotiated dollar column. A percentage is the second most preferred, and the algorithm is the last resort. So maybe you have a percent of a payer's fee schedule that maybe you don't have your hands on. That is where we would put this information. The estimated amount, so this is determined using historical reimbursement. So if a standard charge for the payer negotiated rate is listed as a percent or an algorithm, you have to ensure that you have an estimated amount listed as well. Now, the estimated amount is usually derived from the 835 remit data, and that's what we do here at HPS to populate what is actually coming through from the payers for that value. Standard charge min and max, I kind of talked about that earlier when we were talking about the 2021 requirements. This is still the same. They want to see the de-identified minimum negotiated charge and the maximum negotiated charge across all your payers. Standard charge methodology, this is where you are listing if something's fee schedule or per diem or percent of charge, whatever that might be. And then additional generic notes. This is where you're going to put additional detail if you've got charity care policies for a particular item, if you've got no applicable data to be able to calculate something, you would put that in the additional generic notes. Again, I encourage you to check out the information available on the CMS GitHub, which is linked here. So once we do all that and bring it all together, this is what the output should look like. Like you see at the top, we have our affirmation statement and kind of a list of that hospital and their location. And then we start listing out at the bottom the various standard charge components. Now, each hospital must make a good faith effort to ensure that this data is true, accurate, and complete. I've also included at the bottom of this file, and you will receive these files after today's presentation. There is a file named Wizard, and what that is you go to that link, and it allows you to input all of the information needed to create the file name according to the naming convention required by CMS. And then once that is done, you can run the entire thing through an online validator tool. And that, again, allows you to identify any potential issues with the file. Maybe there's a column that says you have to have, you can't have blanks, right? It will tell you that you have blanks in that column or whatever it might be. So I encourage you to take your files and run them through the validator whenever possible. So now that we've built the file, there's a couple of things we have to do to make sure that it's published in a compliant manner. And this is where a lot of hospitals get a little tied up and a little confused. And this is kind of the basis of where we see hospitals getting compliance letters are in these next two slides. First off, the text file link. So the text file is how CMS is searching for your files. So it's not used for patient use, but it actually lets web crawlers or machines easily locate the file. So you must have it created and added to the root folder of your website. If you don't know what that means, your webmaster or your web host does. And this ensures that it's just added to the correct location, again, at the root of your website. For example, if your hospital web address is www.hospital.com, the text file must reside at www.hospital.com/cms-hpt.txt. Now, the CMS text file generator, again linked here, is another great resource to help you create the file that needs to be held at that location. Now, this isn't the MRF itself. We shouldn't put the MRF here. It's just a text file about where to find the MRF and where to find your estimator. So you'll see in the upper right-hand corner an example of what your text file would look like. Now, next, CMS requires hospitals to have a link in the footer of their webpage called price transparency. No more, no less, just price transparency. And now this would be found where you have links to maybe policies, about us, etc. And this link should take users to the source URL that you have listed in the text file. So let's go back. That source URL is your maybe hospital.com/price transparency, or maybe it takes you to some other financial resources page. But that link needs to match where this is going. Now, this link also needs to take you to a place where you can directly download the MRF and you can access the estimator. That's important. So if CMS, it can't find your text file, they come out, they find this price transparency link, they go to it, it should include a place to download the file and access the estimator. Now, as you can see in this screenshot, this hospital actually has the CMS required price transparency link in the footer, but it also has a little bit more of a consumer-friendly link above that says pricing and price transparency and out-of-cost price estimator tool. That's fine. CMS is just still going to be looking for this price transparency footer saying only that. Now, since 2021, let's talk about the second requirement a bit. So the second requirement for price transparency, for the most part, has remained the same. And this is a listing of consumer-friendly shoppable services. Now, according to this requirement, hospitals must include a secondary document, which is also accessible on the public website with your MRF, that includes a list of at least 300 shoppable services that can be scheduled in advance by a healthcare consumer. Now, these 300 services include 70 that CMS has already decided beforehand. So they have a list of 70 that you have to provide information on. And then the remaining 230 are decided at the discretion of the hospital. Now, there's no designated file format for this particular requirement yet, but CMS hopes that this requirement will further the availability of the publicly accessible shoppable data to better compare services across healthcare settings. Now, each of the 300 or more shoppable services needs to include the gross charge, discounted cash price, payer-specific negotiated rates, and that de-identified minimum and maximum negotiated rate. I've also included a link here to a CMS kind of FAQ steps to creating this file if you have questions on it. What's important here, though, is in this file, in addition to simply including the primary shoppable service, you also have to post the charges, services, and items that are typically associated with that shoppable service. And then also identify any charges of that service that may not be directly billed by the hospital, like your professional or practitioner fees when they're not performed by the hospital. Now, most hospitals will actually kind of do the alternate to this. And the alternative to this requirement is to create an internet-based price estimator tool. Again, a lot of hospitals use this route. It's just a little simpler. Now, this tool must meet the following requirements. It does have to provide estimates for the 300 shoppable services, including those 70 by CMS. It needs to allow the healthcare consumer to, when they use the tool, obtain an estimate of their financial obligation for the hospital service. So it can't be a link to call someone else to get a quote. It has to be within the tool. And then finally, that it's prominently displayed on the hospital website and accessible to the public without charge and without having to register or establish a user account or password. Now, as I mentioned earlier, this requirement hasn't really changed over the years. This might be the area that we see a little bit of a change coming up in the next year's ruling. I have a little bit of a gut feeling on that. So we might see some changes to this coming up. One of the things that kind of has always been a point for us as we've been working with clients is that last point about it being prominently displayed and accessible without having to register or establish a user account or password. For some estimators, they do require a patient to enter personal information before they get the information. That might become a no-go moving forward. So as we're looking forward, as we're looking into this, we need to make sure that we are altering our websites, making sure that they don't have to put in their personal information in order to get a quote. So again, total speculation. Maybe someday down the road, we'll see some changes to that. Now let's talk a little bit about civil monetary penalties. I know you guys have seen this before. I won't spend a ton of time on this, but the non-compliance can be up to $109,000 for small hospitals and as much as $2 million for larger hospitals. But the good news is CMS is really great about providing steps for us to resolve issues before getting there. So there's several steps that can occur prior to the monetary penalty being assessed, including a written warning of a specific violation, a request for a corrective action plan, and then, from that point, we would see a monetary penalty. Now, deficiencies are published on the CMS website, and the window of time to correct these deficiencies is actually significantly decreased as we're getting further and further along in this process. Again, this started back in 2021. Back in the day, it was more like almost 300 days to fix this. Now it's down to 90 days. CMS is being stricter on that enforcement. They want us to be moving forward and correcting these issues and getting things done more timely. Now, probably the reason you've joined me here today. On February 25th, 2025, the White House reinforced its commitment to price transparency with a newly issued executive order called Making America Healthy Again by Empowering Patients with Clear, Accurate, and Actionable Healthcare Pricing Information. Now, this order signals a significant shift towards stricter enforcement and compliance requirements for hospitals and health plans. The executive order from a hospital perspective calls for stronger enforcement of price transparency rules. So no more leniencies on noncompliance. In fact, we anticipate that corrective action period will likely become even shorter. Like I said, it's 90 days now. We might see it shrink down to 60 or 30. They're ready for us to get this figured out. Next is the full disclosure of actual prices and not estimates. So we must ensure that accurate and complete pricing data is in this file. And then finally, standardized comparable pricing information, making it easier for patients to shop for care. So again, maybe some changes to that estimator coming down. Now, according to the executive order, the president had required the Secretary of Treasury, the Secretary of Labor, and the Secretary of Health and Human Services to take necessary action to rapidly implement and enforce price transparency within 90 days of that order. So on May 22nd, 2025, CMS released an updated guidance to assist in implementing the executive order. Now, the requirements haven't changed. So I want to make very clear, the requirements haven't changed. We just have better guidance and clarification on what's already out there. So again, regulations have not changed and likely will not until the OPPS final rule has been released. I believe that comes out October-ish, so we'll be looking for that for sure. But CMS has clarified 2 points of the current regulations as it relates to hospitals. First, if a value can be listed as a dollar amount, it should be listed as a dollar amount, which I covered earlier in our presentation. CMS expects that hospitals can calculate and encode case rates, fee schedules, per diem rates as dollar values. Now, in some cases, that negotiated rate is a percentage off of a fee schedule, and maybe that may not be available to the hospital. In this case, hospitals can indicate if it is a percentage and provide information about the type of fee schedule in the additional notes column, while listing an estimated allowed amount from that 835 data. So there is a way to still list a value when we're looking at this. Now, again, the important thing about this data is to ensure if something can be coded as a dollar amount, it should be coded as a dollar amount. Second, hospitals have been instructed to discontinue encoding 9 nines for the estimated allowed amount. So the estimated allowed amount is defined as the average dollar amount that the hospital has historically received from a third-party payer for an item or service. Again, we pull that out of the 835 remittance data, but there may be instances where a hospital has limited historical claims to derive the value, which is why CMS previously allowed the use of the 9 nines in the field. Now, however, hospitals should actually use the allowed amount from that 835 transaction data from the previous 12 months to determine the values. If an item or service was performed 1 or more times within the 12 months prior to posting the file, the hospital should encode the average of the charges from the data. But it's important that a remark is included in the notes column that says there was limited volumes, whether there was only 1 claim, whatever that might be, just to ensure that we have indicated that that might be a skewed value, right? So if an item or service was not used within the 12 months prior to posting in the file, the hospital should encode an expected value from the negotiated contracts and remark in the notes that there were 0 instances of the item or service in the 12 months prior to posting the file. Again, this guidance is consistent with the previous year's final rule, but it provides more clarity on really encoding these values. Now at HPS, we continue to monitor changes to this rule and will remain proactive in sharing information with our partners as soon as it becomes available. In the meantime, though, there are a few things that hospitals can do to ensure that they're ready for these next steps. First, creating transparent pricing strategies is a great way to ensure that when we are asked by patients or payers, you can explain your pricing methodologies. Now, in general, there are 3 primary pricing strategies. We have reimbursement-based, cost-based, and market-based. But many times facilities will use a combination of these strategies. What is also important is the ongoing maintenance of pricing. Hospitals have done it for years, just implemented a uniform price increase year over year. Now, this was deemed sufficient prior to the era of price transparency, but this practice involves raising all prices by a set percentage each year without consideration of the market conditions or competitor pricing. With the advent of price transparency, it's pretty obvious various stakeholders, including consumers, the press, and researchers, now have access to this detailed pricing information. Even though the MRF was not intended for patient use, anyone can pull that information down. Now, this shift has significant implications for hospitals that have relied on uniform pricing increases year over year. So specifically, a service that was priced high maybe a decade ago may have now become excessively expensive due to compounding annual increases. Now, this can result in public scrutiny and risk the hospital's reputation. The new environment necessitates a strategic approach to pricing. Hospitals should consider market data to make informed decisions about which prices to adjust up and down. Some prices may need to be increased while others lowered to remain competitive and avoid those pitfalls of price transparency. Adapting to this approach will help hospitals align their pricing strategies with market expectations and mitigate the risk of negative perceptions. Creating that sound pricing methodology is the first step in achieving our price transparency goals and improving the patient experience. These strategies ensure that prices are justified either according to a Medicare fee schedule, actual costs, or your peer market. Implementing these best practices can help to improve profitability and create justified pricing methodologies that ensure transparency, competitiveness, and earned reimbursement. Also, identifying patient-sensitive items and competitive items also help the facility with becoming more retail-oriented in this new price transparency environment. Now, one thing that I know everyone has seen, especially if you subscribe to Becker's Healthcare or something like that, a lot of things are coming down as it relates to payer contract reimbursement, analytics, things like that. So in the dawn of price transparency requirements, payer contract negotiations, reimbursement analytics, denial management, these are going to become a primary focus for hospitals. So hospitals must ensure they're doing several things. First off, if any contract includes a lesser of language, the facility must ensure pricing is established in such a way to ensure maximum revenue. Now, some managed care contracts include a lesser of language, and what that means is they will limit your reimbursement to either a DRG rate or the total of the charges, whichever is less, right? Or a HCPCS lab charge or the current reimbursement, whichever is less. So if a hospital is trying to be proactive to become better with their price transparency file, to reduce prices, become more in line with the market, they might actually lose revenue because of these lesser of provisions, unintentionally. So since more patients are shopping the market for services, our recommendation is to ensure that the hospital prices are in line with the market average of the selected group. And then once that's been determined, we then compare that to any managed care fee schedules to confirm that that market-based price is at or above your fee schedule to ensure you're getting maximum reimbursement at the line item level. So again, it's a small thing, but it's a very important thing. Now at HPS, when we're developing new charges, and a lot of times hospitals have this as well, we like to see new charges priced at a multiple of Medicare reimbursement. Now, this refers to the OPPS rate from Medicare. Now, if you're a critical access hospital, you might think that the OPPS reimbursement doesn't matter because you're reimbursed on cost. And yes, you're right. But many times we find that hospitals may have contracts that relate to the OPPS Medicare payment rates, even as a critical access hospital. So I was working with a hospital that had a contract that said reimbursement will be 3 times the Medicare OPPS payment rate or the current charge, whichever is less. So the hospital was leaving money on the table because they did not consider that the contract was based on OPPS payment rates and didn't think it really related to them. Now, also keep in mind, Medicare payment rates are intended to represent the cost of providing the service. We know that that's not the case, but we need to ensure that our prices are above that value. Now, private payers set hospital prices through contract negotiations. We know that, right? If providers and payers are unable to reach common ground on a contracted price, the payer or the provider will consider themselves out of network, which then pushes patients away from the hospital or hospital system. Hospitals have to be agile in their ability to model contract rate proposals from payers to evaluate that financial impact. Now, we have to remember large payers like United Healthcare and Anthem have armies of data economists at their disposal to ensure that they're going to win at the end of this negotiation. And we know that hospitals don't have these types of internal resources. Now, some hospitals might contract with an outside vendor to be able to kind of manage, evaluate, and optimize those contract negotiations, but others, most do not, and they just kind of hope for the best. But during the negotiation process, it's important for hospitals to really understand if they're even being paid correctly in the first place. And this is where we're starting to see a pivot towards things like denial management, things like underpayment identification. As I like to say, it's important to know where you sit, before you tell others where you stand. So when we're going into these negotiations, hospitals need to have the data available to them, understanding how payers are behaving. Are they playing well in our sandbox according to our contract terms? And that is starting to be what many hospitals are focusing on moving forward. Now that price transparency is almost in the rearview mirror, again, I think there's going to be more coming down in October. But for the most part, we've got a pretty good handle on what we need to do from that perspective. And now we need to go into survival mode, make sure that we're getting paid what we're due in all instances. Let's see. So that went fast. So this concludes our discussion of the hospital price transparency requirements. I really do appreciate your time today and thank you for joining us. I know Steve's going to get some questions for me here soon. As a thank you for joining us, we are offering a free market report for up to 4 of your peers if you'd like to take a look at that. To take advantage of that offer, please email Rick at the email on this slide and include webinar HPS in the subject line. And this offer will expire, let's say, August 1st, my birthday. Why not? Let's go there. All right, Steve, do we have any questions?
Yeah, Randy, thanks so much. What a great presentation. People, if you have questions, please enter them in the Q&A box. But while we're looking at that, Randy, I've got a couple of questions I want to ask. You know, it's been a long time since I worked in a hospital, but balancing transparency compliance with competitive pricing concerns, do you have advice on how to do that?
Yeah, you know, I have a whole nother presentation on pricing, but, you know, it's a great question. We recommend really identifying and pulling out those items that are price sensitive, competitive in the market. Maybe you've got a freestanding imaging center down the street that's killing you on CTs, whatever that might be. Reviewing how your negotiated rates compare with kind of the market benchmarks. Now, CMS doesn't prevent hospitals from being competitive. It's just encouraging transparency. So by using that data, understanding how other hospitals are kind of getting reimbursed, how they're charging for things, you can really get a good handle on where you need to be. So we focus on pricing defensibility and payer contract strategy. that allows us to remain kind of compliant and strategically positioned within the market. So you've got to have an eye on a few things when we're doing that.
Great. A question that's just been sent in. If you add new services during the year, do you need to upload a new file?
Oh, great question. No, as of right now, CMS only requires the update to happen annually. So if you upload your new file tomorrow and you create new charges a week from now, you don't need to put those up right away if you don't want to. You can wait that 365 days. If it's something that maybe is going to be a shoppable service or something of interest, it doesn't hurt to go ahead and update, but it is not required by CMS.
Great question and great answer. You know, as you work through this, Randy, what are some of the most common compliance mistakes you're seeing with the new CMS MRF template requirements? What are some of the common ones?
Yeah, so we're still seeing a lot of issues, and primarily it's related to the incomplete adoption of the new CMS template. So whether we're missing modifiers or we're missing NDC values, things like that, we're still seeing some stragglers when it comes to that. Also estimated allowed amounts. Now, we're also, and I just got a letter earlier this week actually from a client who inadvertently did not implement correctly on their website. And so what we're seeing a lot of times is maybe that text file isn't available or isn't built correctly or doesn't have the right source URL in it. Again, small oversights that can trigger you getting a compliance letter. So our team has been very good about getting out there, making sure that those are cleaned up and ready to go.
You know, I know we're about halfway through 2025. In your experience, are CMS audits becoming more aggressive or they're becoming more numerous? What is kind of your take on it?
Absolutely. We are definitely seeing an increase of audit activity. In fact, we get some of our newest clients because they've received a letter and they come to us because we can quickly get them going again. But it really is related to the file discoverability, naming conventions, the format of that file, the text file placement, the CMS template usage. Those are really the top enforcement targets right now. And so again, it's one of those things where yes, they're getting more aggressive, but we advise our clients to make sure that they're internally making sure that things are following the letter of the rules and we stay ahead of those potential findings.
Good point. You know, I know you touched on this in your presentation, but let's think about these patient estimators. In your view, how big a role do they play in price transparency compliance?
Yeah, so again, patient estimators are used to fulfill the second requirement of price transparency, and that's our publication of the 300 shoppable services in that consumer-friendly format. So many hospitals have implemented them, and we want to ensure that those are in step with the machine readable file data. So the estimators, I think, are going to be more robust moving forward. Those are going to provide more meaningful pricing information. Remember, back in 2021, 2019, President Trump said, we want meaningful pricing information. This MRF, we all agree, is not meaningful to a patient. So the estimator is going to be the way to go. So I'm really hoping that we're going to see a little bit of a shift in that as we develop those tools and make them better for patients.
Yeah, that's a good point. You mentioned what President Trump said, and during your presentation, you also mentioned his latest executive order. And I know we're going to get additional information in October. But if you had to pick like one or two big pieces of advice from the way you see it, Randy, what would you say to hospitals that they need to do to truly improve their price transparency strategy this year?
So I think we need to stop thinking of transparency as a compliance task. I mean, we know it is, we've got a box to check, but it also needs to be a strategic opportunity for us. We need to be using that MRF data to analyze how our pricing not only compares to other facilities, but within our current payer contracts. Maybe how is United reimbursing compared to Anthem, right? Being able to use that information to our advantage. We can use that MRF data again to analyze how the prices compare regionally, but how payer contracts affect that competitiveness and where opportunities exist for maybe creating rational pricing structures. And hospitals that treat this as a visibility and planning tool, not just a checkbox, are going to be the ones that get ahead of this.
Good advice. And I know this sounds like a silly question, but I'm going to ask it anyway. Should hospitals worry about patients actually using the data?
Oh, yeah. I think more and more we are seeing patients being able to pull these files down. Now, do they truly understand them? Maybe not. So the usage is currently limited, but I believe that the momentum of them are currently our current policy making, payer pressures, all of that is growing. So patients, regulators, and competitors are really all watching this. So ensuring accuracy and accessibility, regardless of the end user, are going to be critical, even if we're not seeing much happening with patients today.
If you have questions, please put them in the Q&A. And while we're waiting to see if there are any final questions, Randy, I think it's worth you going back one slide and just reminding people the gift that you said you were going to give up to your birthday, August 1, to look at this free market pricing report. I think that's really a good thing for you to reiterate.
Yeah, absolutely. So at HPS, we have access to the Medicare claims data, and that is what we use for our pricing projects with our clients. And so we are offering an extract of that data for you and your 4 peers so you can kind of see how your gross charges align across there. So this isn't payer rates. This is actual charge claims comparative data for you, which might help you kind of identify those shoppable services within the data and maybe get a little bit more competitive for those items, especially when it comes to your price transparency tools.
Well, Randy, this has been a great presentation. We've had some good questions. You've given us really good advice. And on behalf of the Hospital Council, we want to thank you, and we want to thank Rick and thank Faye and the entire team for all the great work you do. And we really appreciate this excellent webinar, and thank you very much.
Thank you all. We really appreciate your time. If you are too shy to ask a question, go ahead and send us an email. We'd love to hear from you and help you out. Thanks, Steve.
Thank you. Everyone, have a good day.